So good evening and welcome to tonight's live webinar that we have in the OrthoCarolina monthly series. So thank you for joining us tonight. We have Dr. Greg Kurkis and I'm Brad Ellison. We're here to talk about the pros and cons of hip replacements. And I'd like to say thank you for joining through the different platforms that are either Facebook Live or LinkedIn or YouTube. Yeah, it'd be great. So YouTube. So thanks for joining those different platforms. We're going to go through the presentation, which will hopefully address some questions or interest areas about hip problems and hip surgery, such as hip replacement. And if there's any questions that are generated, please feel free to comment those on the different platforms that you're using to listen in on, and then we'll try to get to those at the end. So thank you again for joining and hope this is educational for everyone. So a little bit about myself. I'm an orthopedic surgeon that's been in practice for about 15 years. And kind of a local from North Carolina, not too far from here. And then went to Davidson College for undergrad and UNC Chapel Hill for medical school, and then through Ohio State and Washington University for my fellowship in orthopedic training. And I've been working at the OrthoCarolina Concord office for about 10 years, where I specialize in hip and knee preservation, replacement, and revision surgery.
And I'm Greg Kurkis. I'm in our Huntersville office. Similar to Dr. Ellison, I did a hip and knee replacement fellowship out in Denver, Colorado, undergraduate at Washington Lee in Virginia, medical school at UVA, and then residency at Emory. My practice is somewhat similar to Dr. Ellison's, and primarily hip and knee replacement, and also some other hip and knee conditions we address beyond replacement as well. So first of all, just to give a basic kind of background, what is a hip replacement? So essentially, it's where damaged bone and cartilage is removed from the hip joint. So the two parts of the hip joint being the ball of the hip, or we call the femoral head, and then the hip socket or acetabulum. And we're essentially replacing those deficient or worn out pieces of anatomy with prosthetic components or implants, which are generally made of metal. Typically titanium is the most common metal, and then there are different liner options that form the bearing surface of the new artificial ball and socket, but often polyethylene or a high density plastic liner is most commonly utilized to make up the components of a hip replacement. And there's just some images here that kind of demonstrate just an illustration of what some hip replacements look like. There are lots of variations between different designs and companies, etc. So
yeah, and so I think at the end of the day, it's basically the hip joint is a ball and socket, and it's worn away for whatever reason. There's a lot of different reasons that someone's hip joint can wear away. It can be osteoarthritis, which is wear and tear arthritis that we kind of get as we get old and have too many birthdays. And there's rheumatoid and inflammatory arthritis, where there's some autoimmune impact in our joints that can impact not just the hip, but other joints as well. If someone were to have an injury to their hip, whether it could be a dislocation or a compaction or impaction injury, they can get arthritis in their hip at a later time in life. Some other conditions can lead to collapse of the ball or changes in the joint that can cause problems in the hip that might need to be replaced as well. Other anatomical or structural problems in the hip can develop and lead to a problem that might require hip replacement. And then finally, trauma, where some people may know their grandparents have had an injury, or someone that they are familiar with through church or whatnot, and they can fall and break their hip. And that might be a situation that would be best treated with hip replacement as well.
So one of the questions that we often get in the office when we've gone through conservative treatment modes and options initially, and those have failed over time or not given folks adequate relief, is we start talking about hip replacement. And then a big question that often comes up is what approach do you use for your hip replacement surgery? And by approach, we mean essentially the how you access the hip joint, the method or direction by which you cut through the skin, tissues, underlying muscles, fascia, etc., to basically be able to do the surgery, to access that ball and socket that we were mentioning earlier, in order to effectively and safely perform the surgery with kind of minimal damage to surrounding soft tissues and everything like that. So if you look at the different approach options around the hip, the two most common ones I've highlighted here in yellow. So the first is the posterior approach to the hip replacement. Posterior meaning kind of the back or side part of the hip. And this is, certainly I think probably considered by many to be the oldest quote unquote gold standard approach to hip replacement that has certainly the longest track record and history of use previously. Over time, as techniques have developed and and varied even regionally throughout the country. Some other approaches have been developed and used over time as well. So going from basically back of the hip towards around to the front of the hip, there's what's called the direct lateral approach, which is more from the side of the hip. There's what's called the anterolateral approach, which is kind of on the margin between the side and front of the hip. Then there's the direct anterior approach, or quote unquote anterior approach, which is more from the front of the hip. And then this is super uncommonly used, at least in this part of the country, but there's also a superior approach to the hip as well, which has sometimes a 2-incision technique that seeks to access parts of the hip from basically the top portion of the hip as well. For the purposes of this webinar and just, the majority of surgeons in the Charlotte area generally use one of these 2 highlighted approaches. So we'll kind of focus the discussion on these 2 just to keep it most relevant for everyone. So.
Yeah, that's great. Dr. Kurkis gave a great synopsis of all the different options, and hip replacement's been around for really over about 50 years. So there's been a lot of evolution in techniques and instruments and implants during that time as the technique and procedure has continually been improved upon through generations of hip replacement surgeons. And so this is a nice diagram that kind of shows you basically what we're talking about with approaches, especially where the skin incision is and what the muscles and nerves and other structures that we have to work through to get down to the worn out hip joint to remove the diseased and deformed hip, to put in the instruments to implant a new hip replacement. And so you can see there, direct anteriors are kind of over the front side of the hip, and the other incisions are kind of on the side or in the back side. And that's just where the location of the incision will be placed, and then kind of where the surgeon will kind of guide the technique to do the hip replacement safely.
So I think this is kind of an interesting slide. As with anything, in healthcare and medicine, we're consistently looking for ways to improve outcomes for folks in terms of how they recover from surgery and long-term outcomes as well, how long hip replacements last. And our goal is really to get folks back up and move in, return to your baseline activities so you can get back to doing whatever it is you like to do, want to do as quick as you can after having, whether it's hip replacement or any other surgery in our practice. So this is from one of our annual hip and knee surgeon meetings from last year, where every year they survey surgeons around the country, everyone in attendance at the meeting, which I think is probably over 1,000 folks, I would think, each year. And basically a survey of, what are you using as your primary go-to hip replacement approach? You can see it goes from basically, 2009 on the left part of the screen all the way up until 2024. The darker line, which starts off high around 65% in 2009, represents posterior approach hip replacement. So certainly, as we mentioned before, historically the posterior approach was that kind of gold standard, most commonly used way to approach the hip, I think across the country. You can see over time, and the dotted or lighter colored line represents anterior approach surgery, which back in 2009 was, just north of 10%. So you can see over the past, 2 decades roughly, you can see a significant increase in trends across the country as folks use the anterior approach more frequently, to where now there's more anterior approach surgery being done nationwide. This study suggests about 65% versus about 30% posterior approach. So again, just a change in practice patterns. And I think a lot of that has to do with, as folks, their training, as things gain popularity, as we come through residency fellowship and gain different exposure to this, and technology improves as far as, the implants and instruments we have available to us improves as well, and adapts to these different approaches. That can certainly help, move some of these changes in practice patterns.
Yeah, I think those are good points to kind of really highlight how there's been a little bit of a paradigm shift over time, where the posterior approach was kind of mainly what I learned in my training coming through, and probably also for Dr. Kurkis and some of our colleagues. But over the past kind of 10 to 15 years, we've seen some advantages through the anterior approach. That may be why we're seeing a little bit of that paradigm shift now, where probably more surgeons are considering the anterior approach for hip replacements and talking to their patients about that, but still keeping that posterior approach kind of in there, offering to patients. And that is kind of where we're talking about tonight, where, just because there is an anterior approach and a posterior approach, the surgeon typically works with their patients on deciding what that best approach for their patients needs to be. And so in terms of kind of deciding what an anterior approach might be best suited for patients that need hip replacement. You go through different criteria, whether it's the anatomy of the patient. Sometimes if there's a big belly on a patient, that can kind of have a tendency to kind of overlie where that incision might be, and that could present a problem for wound healing. There's other deformities around the socket or the ball on the femoral side of the hip. There could be some difficulties in accessing those structures safely and reliably to remove the disease and correct that deformity through an anterior approach. So a posterior approach might be better suited in those particular patients. And so these are some of the reasons that kind of help surgeons kind of decide which patients might be best served through an anterior approach versus the posterior approach. So again, it's back to anatomy, body habitus, whether or not they've had other surgeries or scar tissue or incisions around the hip. If they have prior trauma or some hardware around the hip that may be difficult, if that hardware needs to be removed, there may be a certain additional incision that might be needed to get that hardware out. Again, back to training. At the end of the day, the surgeon needs to do the procedure the best way they know how, and their familiarity, training, and experience will have some impact on that. And we've seen over time that the long-term outcomes are relatively equivalent when comparing an anterior and posterior approach surgeons, as long as the surgery is done appropriately and the technique is reasonable and the implants are put in the proper way, is that the long-term outcomes are roughly equivalent. There might be some short-term advantages with the anterior approach. We think that maybe a little less pain, a little more muscle sparing, a little quicker to move and get back to work. And overall, maybe some limitations in instability or the ball popping out of the socket, which have some advantages with that hip approach. But there's going to be a kind of a case-by-case decision based on what the patient and the surgeon need to kind of accomplish through that surgical consideration.
So talking a little bit about the anterior approach. So again, the front of the hip incision. And speaking of incision, with the anterior approach, you may have friends or seen online or in your own research, incision from the anterior approach. The vast majority of anterior approach incisions are longitudinal, meaning it goes in line with the axis of the leg. There are some surgeons, in our group and throughout Charlotte, they use what's called a bikini approach incision, which is more of a diagonal incision that kind of follows that groin crease in the hip. Another thing to discuss with your surgeon if it's something you're interested in from a cosmetic standpoint. But again, like Dr. Ellison said, I think regardless of technique or approach that's used, for me, the most important thing at the end of the day is getting the implants in optimal position to kind of recreate the anatomy of the hip joint with as minimal soft tissue damage and injury as possible during that process. Because I think that gives folks the best outcome long-term and quicker recovery and all that kind of stuff. So, so pro versus con, just in my mind, comparing those for the anterior approach, as Dr. Ellison mentioned, the anterior approach is an intermuscular, internervous plane, meaning that we do not need to split any muscles or cut any muscles or go across a plane where a nerve innervates muscles or tissues on both sides of that incision, or deeper layer. And so there's technically no cutting of the muscle. We do think that might contribute a little bit to the quicker, ambulation and walking and a little earlier recovery for folks after anterior approach hip replacement. Most surgeons don't require formal hip precautions after anterior hip surgery. And when I say hip precautions, I basically mean positions or motions of the hip to avoid for that first 90 days or so after surgery. And the goal and worry behind this is, a complication of hip replacement is dislocation, where ball will pop out of socket post-operatively. Obviously not a good thing to happen. So we try to limit the chances of that. And so with the posterior approach, sometimes you will have some of those precautions to limit that risk. With the anterior approach, that is less of a concern typically, and so we don't require those limitations on folks. There have been some studies to show that the anterior approach may have a decreased risk of dislocation. In a lot of the studies, this is a very small, decreased risk, but may exist for some folks to kind of go along with the reduction in hip precautions. Personally, from a surgeon's perspective, one of the reasons I like the anterior approach a lot is for intraoperative use of X-rays. So I am able to take X-rays throughout the procedure because you are laying on your back, and we have good access from what we call a C-arm, which is a basically mobile fluoroscopy, an X-ray machine that can come in and take pictures essentially live during surgery. And it helps me know and ensure that I'm putting the implants in the position I think, in a location that I think will best recreate the anatomy for that patient. And also it helps with assessing leg length too. With hip replacement, you can modify the length of someone's leg. So oftentimes in advanced hip arthritis over time, as the ball wears away that cartilage cushion in the hip will actually shorten slowly over time. And it's such a slow process that most folks don't typically notice that difference until it becomes very severe, progresses a lot over time. So with hip replacement, oftentimes we will lengthen the leg a little bit to restore that native anatomy. And the x-ray allows us to compare to the other leg and exactly try to match up the hip lengths intraoperatively. Now you can do this without x-ray, just from manual palpation and feeling of the ends of the legs and feet during surgery. But for me, it's just another check to make sure that we're lengthening the leg an appropriate amount to make sure that folks minimize the chance that they have a perceived leg length discrepancy after surgery. So some cons or downsides to the anterior approach. So as Dr. Ellison mentioned, wound issues, I definitely think are more common with the anterior approach surgery. So if you think about the skin around your hip, in general, the skin over the front of the hip tends to be a little thinner. And as you get up into that kind of groin crease, or if you have a little bit of a belly that overlies that area, it's an area that, moisture can sit in, and it doesn't always provide for the best wound healing options. So there are, some reports that say that anterior approach surgery has a slightly higher rate of wound issues superficially. That has not translated in the research to say that there's an increased deep infection rate, though, with anterior approach hip replacement. So, sometimes this takes the form of, you might have to put in some extended, dressings over the top part of the incision, or leave the sutures in a week or so longer, just to make sure that things heal appropriately. As mentioned previously too, anterior approach surgery can be technically difficult for patients who are, heavier or extremely muscular. So when I think of a difficult anterior hip replacement, it's generally a male who is super muscular, kind of that stockier build, who has a very kind of, to say, like a V-shaped pelvis. So the pelvic wings, kind of those bones you feel on the side of your hip, are wide relative to where the hip socket and ball actually lives. So, the muscles being stronger, bigger, essentially makes for exposure to be a little more difficult. And essentially it's just a deeper, approach in order to access and see what we need to see to do surgery effectively. The lateral femoral cutaneous nerve is a superficial skin nerve that runs kind of over the front and side of your thigh along the skin level. The position of the anterior approach incision can sometimes sacrifice a portion or part of that nerve. And so folks often can report some numbness over the kind of side part of their thigh after surgery. And that can persist up to a year and a half in some studies, and even longer still. There may always be a small area of numbness on that side of the thigh there. I've also seen a little bit in my practice sometimes of some hip flexor tendonitis or bursitis over the front of the hip, which is basically just rubbing of that hip flexor tendon over some of the either hip replacement implants or some scar tissue postoperatively. I don't have data to support it, but I think it might be a touch higher in the anterior approach, just because that's the direction that you're accessing the hip. So,
yeah, all good points. I think that's kind of chronicled well there with what Dr. Kurkis has shared. And then for the posterior approach, we think that it's more extensile, meaning that whenever we do a surgery, we like to use the smallest amount of incision that we think is safe and appropriate to get in and out reasonably by removing the diseased hip and putting in the new hip replacement parts. And so we say that it approaches extensile. It means that we can extend it down the leg or higher up on the hip to access something if there were a need to do so. So it gives us a little more access and options if we need to address any particular problem with the patient's anatomy that might be unique for them, or may change into a different instrument or stem or even cup combination to address different pathology that might need to be treated by a larger incision. The wound incisions, like Dr. Kurkis said, is pretty rare on the posterior approach, as long as someone has good overall healing with minimal medical comorbidities. Again, the revision surgery options are probably pretty good considerations for a posterior approach, just because you can access the femur side and the socket side much more readily through the posterior approach, although revision surgery can be done safely through an anterior approach with a skilled surgeon as well. We do think that there is a learning curve to learning that anterior approach, like Dr. Kurkis has shared, that it's perhaps a little more technical in some of the aspects of doing that procedure. So the learning curve, meaning that their first 50 to 75 cases of a surgeon learning to do that anterior approach may require a little more operative time. The use of fluoro, kind of getting in and out of the hip safely, may take just a little bit more time, therefore a little more blood loss perhaps as well. But once you get past that learning curve, it's thought that the operative times will kind of diminish and the blood loss will return back to kind of more acceptable or standard levels. And then as we kind of talked a little bit before about the cons for the posterior approach, hip precautions are usually recommended for at least about 6 weeks or so to kind of help keep that ball in the socket, because there is some soft tissue stripping and some muscle weakness that happens that needs to kind of recover in terms of their muscle strength in order to kind of provide that dynamic stabilization of keeping the ball in the socket safely. And we think that maybe some of that muscle stripping done from the posterior approach can lead to a little bit more pain, soreness, inflammation, a little longer recovery perhaps. We think that at 6 weeks, there might be an advantage in terms of recovery with the anterior approach compared to some posterior laterals. But by about 6 months, you start to see those outcomes start to kind of equilibrate, where the pain, function, quality of life, and mobility are have improved nearly equal levels at about that 6 month time point.
So just gathered a few kind of studies to kind of support some of the stuff that we were mentioning as far as, the pros and cons of each of those approaches. So this is a meta-analysis, basically a combination of a bunch of different studies over time, where they basically synthesize and bring together the findings from a lot of different research studies and try to draw conclusions based on those bigger numbers that combining all those together provides. So in this study, they compared anterior versus posterior hip replacement. And in terms of the significant findings that they noted between these, they showed that, as we mentioned, there was a little earlier improved pain and function for folks, in that period, 6 weeks or so after surgery. This study showed a slightly shorter hospital stay. Now, granted, this was in 2015. So I think one of the big changes, definitely since 2015, and probably even more so since the COVID pandemic, 2019, 2020, is that we have had a huge shift to having patients leave the hospital much earlier, majority on the same day of surgery. And accompanying that is kind of a shift to the outpatient surgery centers, ambulatory surgery centers, et cetera, away from the traditional hospital setting. So I doubt you would see, if you redid this study today, I doubt you would see that difference in hospital stay because of a lot of our changes in perioperative management and expedited discharge after surgery. They did show in this study that there was a slightly decreased rate of dislocation, again, ball popping out of socket with the anterior approach surgeries. And they showed some slight decrease in narcotic or opioid pain medication use postoperatively. Again, the findings from the posterior approach, they had slight decrease in intraoperative blood loss. This was not statistically significant between the anterior approach and posterior approach, and also a trend towards slightly decreased operative time. Obviously this could be patient or surgeon dependent, but at that time in 2015, they did not show a significant difference between those for the anterior versus posterior approach.
Yeah, and so I think overall, just kind of looking at comparison studies between the anterior versus the posterior approach, we're kind of seeing more of that kind of trend or tendency to do more anterior approaches, mainly for the thought that the data is showing us that, again, like Dr. Kurkis has said, that we think that we can safely get those patients up and moving and mobilized more quickly, less pain, a little more reliable component position. Like Dr. Kurkis shared, we can use intraoperative x-rays, be sure our socket's where we want it to be, our leg length, our offset, the stem positions where it needs to be. I think there's some enhanced technique aspects that come with the anterior compared to the posterior approach that are a little less difficult to do in terms of using intraoperative fluoroscopy with the posterior approach. A lot of that goes to kind of help, provide some of those improvements for the anterior approach when compared to the posterior approaches in terms of improved outcomes, reduced complications. And over time, like we've kind of mentioned before, the long-term outcomes are roughly equivalent. Again, the main point and kind of takeaway from this is that as long as the hip replacement procedure is done in a reliable, safe way through either an anterior or posterior approach, that the long-term outcomes are greatly improved for patients that need hip replacement. And it's a very successful surgery for many patients in many cases.
So just, a few points to consider that I try to counsel folks in the office when we talk about this is, this can be a very patient and surgery specific decision. As you can see from a lot of the factors that we've talked about, so far in the slideshow here, there's a lot of things that can affect, whether you do an anterior approach, posterior approach, et cetera. So it's certainly something that you can and definitely should talk about with a surgeon before kind of going down this road of pursuing hip replacement. Because it's not certainly a one size fits all mentality. I think in my practice, I tend to do more anterior approach than posterior approach surgery, but there are definitely cases where I feel much more comfortable doing a posterior approach just because of patient anatomy, hardware, all those things we mentioned. So there's not a blanket one approach is better than other. It's very individualized and ultimately is a decision between patient and surgeon about what is best and what will give the best outcome. So as I mentioned before, for me, placing the implants in appropriate, good anatomic position while minimizing damage to surrounding muscles, tendons, tissues, I think is the key to have a good surgical outcome, regardless of what approach you use to get there. And again, to reiterate from previous slides and all, long-term outcomes. So once you get to that 3 to 6 month mark after surgery, there really has been no data to ever say that one approach is superior to another. So I just think it's good to keep those ideas in mind.
So thank you all for joining us tonight. Hopefully that's given you some good food for thought relative to hip arthritis and degenerative conditions and hip replacement. And we hope to provide some information that will answer some of your questions or generate more questions to follow. Please feel free to share those questions and comments with us tonight or even later, and we can follow up as best we can either this evening or at a future date. But again, thank you all for joining in. If you'd like to see this in the future, we can have you join in through the Facebook, LinkedIn, or YouTube platforms that you've used to kind of view things tonight. Feel free to reach out to your OrthoCarolina offices to speak with any of the hip specialists at the different OrthoCarolina practice locations. If there's a consideration for a hip condition and a possible need for hip replacement, many of the OrthoCarolina surgeons can expand upon what we discussed tonight about different approaches relative to hip replacement. So thank you.
So we'll field some questions that have come through. So first question, how does orthopedic research impact your practice with hip replacement approaches? So as you saw on the slideshow, for me, medical literature research really guides, what I think is the best practice and how do we take best care of folks. So, I think most of us are involved in research quite a bit in our training, medical school, residency, fellowship. We have heavy exposure to that, and then once we get out of that training mode, at least in our practice, there are folks who are very much involved in the research aspect of hip and knee replacement surgery in our group, and have contributed significant amounts to the advancement of our field, around the world, honestly. So I have tremendous respect for those folks in our group and appreciate all they've done. But for me, I try to stay as abreast of the literature as I can, attending meetings on an annual basis and, reading journals and trying to stay on top of what is best to guide practice patterns. As you saw from the previous slides, as things have changed over time, particularly with the anterior approach gaining more prominence and popularity, things change over time. So we can't be static in our techniques and treatment strategies from when we come out of training until later in our career, because that's not the best way to take care of folks. So,
Yeah, I think those are excellent points. And one of the unique, I think, aspects of OrthoCarolina is the OrthoCarolina Research Institute, which is probably one of the most successful and prolific musculoskeletal research entities on the planet. And thankfully, Dr. Kurkis and I get to participate in different studies with them at different times. We're working on a few studies now on joint replacement work. We usually have about 82 to 83 peer-reviewed publications put out every year from the different doctors that work with OrthoCarolina. We're always looking at different ways to solve these problems and understand musculoskeletal disease better and improve upon non-operative and surgical techniques. And our research institute has been a really powerful supportive arm in being able to help patients and advance the field of knowledge. And so that's one of the very unique elements with OrthoCarolina, is that we're very committed to research, regardless of where our practice location may be, and being able to provide the latest and most current and up-to-date technology and treatments for all patients with all kinds of different conditions. So can I get this surgery at an ambulatory surgery center, or do I have to go to the hospital for it is the next question. And so I think that's a really good question. Like Dr. Kurkis kind of highlighted, is I think there's been a general trend over the past kind of 5 to 10 years to move a lot of the arthroplasty, so hip and knee replacements and shoulder replacements, into the ambulatory surgery setting. And at OrthoCarolina, we found that we've been very successful with the surgical centers that we've set up that provide a lot of ambulatory care in terms of really improving that anesthesia, the technique, the overall experience for patients and their families that are getting outpatient joint replacement surgery. And as you explore this consideration of needing a joint replacement, or someone in your family may have a need for that, and working with OrthoCarolina and exploring the potential for having that surgery done at an ambulatory surgery center can be very gratifying. It's a very high quality experience. Our surgery centers have some of the highest marks across orthopedic surgery centers in the country. I think the overall cost of the care ends up being very favorable for patients. That's significantly reduced to some of the care that would be offered in the inpatient or hospital setting. So that can be very favorable in these times that everybody is trying to find the best way to stretch the dollar as best we can, and being economically minded with our healthcare.
Yeah, I agree. Like Dr. Ellison mentioned, when folks, talk to me post-surgery about, their experience and recovery and whatnot, consistently, patients that have gone to one of our ambulatory surgery centers, they rave about the experience. I think it's a very streamlined approach to providing, outpatient joint replacement care. The hospitals locally do a great job and take good care of patients, but they're doing all kinds of surgery. They're doing general surgery cases, and other subspecialties that use the hospital as well. At an orthopedic surgery center, it's pretty much the same streamlined process, all day, every day. So it's a very smooth process, and I think that makes our job easier. And I think at the end of the day, patients, have a better experience oftentimes because of that. So I would say, like we mentioned previously with approach to hip replacement, whether or not you're a good or safe candidate for surgery at an outpatient surgery center, it can be patient specific, based on some of your medical issues, age, baseline mobility status, how much help you may or may not have at home, et cetera. So a lot of those things go into that decision. And again, that's part of that discussion in the office, when we talk about and go towards the option of hip replacement, that we kind of address at that point and make sure we make a decision that has the safest outcome for you. So next question, at what point after hip replacement surgery is the patient allowed to go up and down stairs? So in my practice, I generally tell folks that you can go up and down stairs the same day if you need to. I would not make a repeated trips up and down stairs, the day 2, 3, 4 after surgery. I typically tell folks, if you have a bedroom upstairs and don't have sleeping arrangements on your main level, just try to go up once at night, sleep up there, then go down once in the morning and do most of your living on the main level, just to minimize that up and down. You will not damage or injure the hip replacement by walking upstairs. In a lot of cases, our physical therapists or nurses will have you work on some stairs before we let you leave the facility, to make sure that you would be safe to do that when you get home. But I just feel that if you're going up and down stairs a lot post-operatively in that immediate period, it just creates a little bit of pain, swelling, increases some inflammation around the surgery site. So I try to recommend folks just take it easy for that first few days to a week.
Yeah, I think those are great recommendations. And I think that's exactly right. I think that we feel that most patients can get up and walk and move safely and get up and down stairs the same day of surgery. If needed, it's nice to kind of maybe have a few stairs, but not try to go up several flights, like Dr. Kurkis is sharing too, where you can consolidate that healing and recovery area. You basically need to think about, trying to have a safe place where you can rest, get to the restroom, and take nutrition, and not have too many distractions or disruptions to your healing and recovery. But yeah, absolutely. I think you want to get up and kind of get back to walking and exercises, but everything kind of comes in moderation, and working with your surgeon and their postoperative rehab and recovery programs will outline specifically what they feel are appropriate to do at each time point after surgery, usually kind of weekly progressions and increase in activities as the healing would support. So the next question is, what types of patient cases do you see the greatest need for enhanced precision in cup placement, leg length, or offset, or none at all, Love hearing your outlook on technology for cup placement. So yeah, I think these are kind of great elements to delve into that are a little bit more higher level in terms of looking at what our components are, kind of what they're made of, how they work, where they need to be positioned. In terms of this particular question, looking at cup placement and then leg length and offset. So like Dr. Kurkis mentioned a little bit, doing the anterior approach, I think there are some advantages on the anterior approach compared to some other approaches where the patient lays supine or flat, and we can use enhanced imaging like a fluoroscopy unit to come over the patient with some other kind of accoutrements at times to kind of be sure our cup is positioned properly, whether it's forward facing slightly and has a nice kind of orientation so it's going to capture the ball and support it properly. If it's too high, the ball may escape and cause instability. If it's positioned too much towards the back or to the front, that can cause pain or instability as well. And so using some type of supportive references during the procedure, whether again it's an anterior approach or a posterior approach, is important to get that cup in the right position. And then in terms of the leg length and the offset, that's kind of an element that's decided on the femoral side of the reconstruction. So, where do you want to put that ball in relative to the socket position? Do you want to kind of increase the offset by putting it out more? Do you want to kind of make the leg a little longer to kind of make it more stable, or make it shorter for whatever reason you may have to address? And that's kind of done intraoperatively as well by working on the different instruments and trial systems that we use during the procedure to kind of get that leg length and offset and rotation combined of the stem position and the socket position so that they're ideally kind of optimized per patient. Again, that's a very patient-specific need and understanding that goes into each case. And again, using that fluoroscopy, I think, can be very helpful in achieving those goals.
Yeah, I agree. I mean, I think, as far as, precision in placing the acetabular component or cup where we want to in surgery, for me, the intraoperative exterior fluoroscopy is invaluable. So that I really appreciate that. And, for me, sometimes I'll put the cup in initially where I think it should go. And we use trials in surgery to kind of sometimes see, before we put in the real implant, where it'll sit. And I'll look at it and say, oh, I think I can make that a little better. I can deepen it. I can lateralize it. I can medialize it, et cetera, to slightly change that position to make sure it's positioned appropriately, again, to try to recreate that native anatomy. So, technology as far as, placement of the cup, I consider fluoroscopy, intraoperative x-ray, essentially technology in that regard. There's a lot of other items on the market, though, that can assist with that during surgery. Robotics is a big topic that's discussed, widespread now at this point, probably more commonly so within the scope of knee replacement. But, there's certainly some robotic or navigation options for hip replacement as well. Again, really with the goal of guiding where the implants are going in a reproducible fashion. And so, I certainly think it's a developing modality, at least with hip replacement. There really hasn't been, in my understanding of the research, studies showing that there's a significant clinical benefit to using robotics with hip replacement. But, I think anything that can help you improve and your consistency with where the implants are placed, I think ultimately that at some point may translate to better outcomes long-term, but none of the studies have shown that with what we have available technology-wise yet at this point.
Yeah, I think those are all great points. That enhanced technology, we'd like to think, make us better as surgeons and allow us to execute the technique and procedure to the greatest level of success that we can achieve. And the good thing about OrthoCarolina, there are many fellowship-trained hip surgeons that can offer the latest and greatest in surgical technique, as well as some enhanced technology considerations. Dr. Kurkis talked about robotics. There's augmented reality. There's artificial intelligence. A lot of these really exciting kind of elements that are starting to kind of enter into the field of hip replacement and other aspects of orthopedic surgery. And all of the OrthoCarolina surgeons that are in that particular field can talk to you at length about this in the office to kind of give you the pros and cons, as we've tried to do tonight about some of the surgical approaches, about the benefits and perhaps maybe the risks or costs of some of these other technologies, to see what might be the best platform and supplemental technology to use to be sure that you have the best surgery and outcome.
Next question, can you explain what a dual mobility joint is and when it should or shouldn't be used? Yes. So when folks refer to a dual mobility hip replacement, they're referring to the ball and liner construct. And so traditionally, a hip replacement consists of the metal hip socket, and classically inside that metal hip socket is a polyethylene or plastic liner. And then within that liner sits most commonly a ceramic head ball that is attached to the end of the stem. So the actual articulating joint surface in a replacement is ceramic ball on a polyethylene or plastic bearing. A dual mobility hip replacement is, in essence, it's a smaller ceramic ball that goes on the end of the stem of the replacement that goes into your femur thigh bone. On top of that ceramic ball is another ball made of polyethylene. So it's a ball within a ball, and that second ball is made of polyethylene or high density plastic. And then that polyethylene ball then sits in a thinner metal shell that goes inside that metal hip socket. And so initially dual mobility hip replacement, and I think its primary use, at least in my practice currently, is used in cases where we're worried about dislocation, where we're worried about the ball maybe easily able to pop out of the socket. And not to get too much into the biomechanics of hip replacement, but in essence, the larger the outer ball is in the socket, the less your risk of dislocation in some studies. And so in addition, the dual mobility hip replacement, by having a ball within a ball, it allows a greater range of motion of the hip before you start to impinge, meaning that the implants will start to bump into each other. And when that impingement happens, that can lever the ball out of the socket, and that's what can lead to that dislocation event. So for me in my practice, I typically use dual mobility hip replacement in some revision hip replacement surgeries where we violated the soft tissues a couple different times, and there may not be as much muscle tissue, et cetera, to support and stabilize the hip. I think it's protective of dislocation in that setting. I also use them in folks who have cases that aren't traditional, arthritis. If they have avascular necrosis, if there's a labral tear, if there's not a lot of pre-existing arthritis that contributes to a super stiff hip initially, then I think that dual mobility hip replacement construct can sometimes be a little more stable and protective of dislocation. Another time I often use it is with hip fractures, folks who break their hip, and we end up doing a hip replacement for that. Again, along those same lines, their hips aren't arthritic necessarily. They're not super stiff over time. And so when we do a full hip replacement there, the risk of dislocation is higher if you do a hip replacement for a hip fracture compared to hip arthritis. And so a way to combat that and minimize that risk is to use one of these dual mobility hip replacements, which is that ball within a socket. So
yeah, I think that's a great summation of what dual mobility joint is and whether or not that's a technical description or kind of a description for the public. It's essentially a ball in a ball that gets to a bigger ball size that makes it more stable. We think that there's different situations where it may be helpful. Dr. Kurkis outlined a lot of those. Some additional considerations would be someone who's maybe kind of a higher mobile patient. They may have some soft tissue laxity around their hip, or they may participate in activities like yoga or Pilates, where they're kind of want to get back to activities that are going to be a little higher demand, maybe a little bit more hip angles that are not maybe higher risk, would be high risk for instability or dislocation. And so that might be a consideration to think about a larger ball and a more stable dual mobility construct in that situation. Other cases, there's other reasons that people can have hip pain, and going through some cases, you'll find that people have abductor muscle weakness, and muscles are very important to maintain the stability of the hip. Dr. Kurkis has shared that you can have different reasons for why there's muscle weakness. You can have multiple surgeries or prior injuries, or just a fact torn muscle abductor tendon, and that can lead to compromised dynamic stabilization of the hip joint. And all of these things can lend to a higher risk for instability. And so I think dual mobility articulations came about first in France, and it evolved to be a little more widespread in the U.S. more recently. We have thought that it does provide a more stable hip joint, and we think that can reduce the incidence of the ball popping out of socket and addresses some of these other kind of higher activity considerations for people that might be going through hip replacement. But again, just a consideration to kind of mention with your surgeon and your OrthoCarolina team if that's hip replacements being considered, because it may not be appropriate for every case, but it could be appropriate in certain cases. So how does osteoporosis affect hip replacement surgery is the next question. So what osteoporosis is a decline in the bone density around the hip joint. And so the bones are getting softer as we age. Typically, we think it's in our postmenopausal Caucasian females that are over about 65 years or so, but it does kind of happen in males as they get over into their late 70s as well. Other hormonal problems and endocrine problems like kidney disorders can lead to osteoporosis even at younger ages. So it's a very important consideration in bone surgery, particularly in hip replacements. And so we find that patients that have bone density problems like osteoporosis, they might need to have a modification how the stem is fastened to the bone. Now, a large part of cases we'll do a cementless stem, or we'll put the stem into the bone where it's kind of wedged in and secured with the bone kind of growing in and integrating around that stem over a period of time. Whereas in cases with rather significant osteoporosis, where the bone quality may not be particularly healthy and supportive of a cementless stem, we'll use a stem that's going to be cemented into the bone. So it'll kind of grind or actually be secured to the bone through the cement and is immediately stable and doesn't rely on the biologic fixation of bone forming in and around the stem. And so osteoporosis has a very significant impact on the bone health, the technique, and the implants that a hip replacement surgeon will consider in hip replacement.
Yeah, and I agree for sure. For me, a lot of times we can tell if there's some decreased bone density preoperatively just by looking at the x-rays, getting a good history in the office. But sometimes, you'll get in surgery and, you're working, to expose the bone, particularly on the femoral side. The thigh bone side is most commonly when I'm most concerned about this, because the risk of breaking the bone or fracturing the femur during surgery is higher in folks with poor bone quality. So, it's something that is definitely a consideration. And I think a cemented femoral stem is a great solution to that, to minimize that risk of fracture, et cetera. And I think it's something that the research studies have shown that is increasing in use. So, I mentioned previously folks that break a hip and end up getting a hip replacement. In the vast majority of folks that break a hip and have some evidence of decreased bone quality at the time of surgery, I'm using a cemented femoral stem just to minimize the risk of fracture and postoperative complications, which has been shown in a lot of research studies to really minimize the risk of postoperative fracture in folks by use of cemented stem. The hip socket side, I have never not used a cemented hip socket. Historically, many years ago that may have been done. I would say 100% of our hip sockets used in hip replacement, regardless of intraoperative bone quality, we're using a press fit implant that allows for bone ingrowth to the back of the hip socket over time. There are some techniques you can do, kind of under reaming or decreasing the amount of bone you remove before putting in the hip socket, et cetera, that if you're worried about the grip or how tightly the hip socket will fit in there, that you can do intraoperatively to minimize the risk of fracture, loosening, et cetera.
Those are good points. And I think just to get back to the approaches, which we've talked about tonight, sometimes in my practice, if a patient has really severe osteoporosis, we may consider a posterior approach just because the risk for fracture might be a little higher than kind of the standard patient. But I would say that over the past years, we've kind of probably offered anterior approaches to even patients with significant osteoporosis, like renal transplant patients and things like that as well. So I think it doesn't always influence the surgical approach, but there may be some consideration for bone quality and osteoporosis that may have the surgeon consider one approach over the other, and that'll be a very patient-specific consideration.
Next question. Do all total joint patients need to obtain an MRI before surgery? No. In my practice, if by x-ray analysis in the office, you have a significant amount of arthritis, if we see bone-on-bone arthritis, or if there's a fair amount of joint space narrowing, bone spur formation, sclerosis or increased density around the joint, deformity of the native anatomy, to me, an MRI does not really change our decision-making for surgery or conservative management. Because at the end of the day, the things that I consider are, one, there needs to be structural issue to explain the symptoms, which we typically can see on MRI in moderate to severe hip arthritis. Two, we've tried conservative managements and they're not helpful. Symptoms are severe, limiting to daily activities, not able to do the things typically you'd like to do or want to do. And then, medically, you're healthy for surgery. So for me, in the vast majority of cases, an MRI does not change the decision-making process to proceed with surgery. Now, there's some cases where, x-rays look okay, and then we've tried a bunch of treatments and that's not successful, and the patient still has a fair amount of hip-centered pain, and we obtain an MRI or MRI arthrogram to look for labral tears, avascular necrosis, or bone death within the ball of the hip joint. So there are certainly some cases where I think it's helpful to have that data ahead of time to kind of solidify our decision making and diagnosis. But for the majority of patients who present with hip arthritis, I do not think an MRI is necessary.
Yeah, I think that's well said. Where I think that radiographs or plain X-rays are what we do in the OrthoCarolina office, where any patient that's coming in to be evaluated for a hip condition, usually we'll start off with plain X-rays, looking at the front and the side of the hip to help understand the bony anatomy and whether pathology may be a part of that. And that's usually the main form of classifying whether someone's hip arthritis is mild, moderate, or severe. And if you're in that moderate to severe category, hip replacement may be a consideration if all the non-operative treatments have been exhausted. And so I think, where I'll find maybe an MRI could be helpful are in cases where the patient may be a younger age, like coming in 50s or younger, with pain that's kind of been recalcitrant to the non-operative measures. And maybe the radiographs aren't as informative and do not suggest rather severe arthritis. And so there may be some other pathology, torn cartilage, torn tendons, other things that can sometimes get to that. We mentioned avascular necrosis, so sometimes that's more sensitive or picked up more commonly on an MRI rather than a plain X-ray. And so an MRI is not necessary for joint replacement patients to have before their surgery, but in some cases, a doctor may decide that MRI does provide more comprehensive information to help understand why a patient is having pain if the X-rays are not sufficient in doing so. So the next question is, can joint replacement be done preemptively in cases of severe osteoporosis? So an interesting question. I think that we think of osteoporosis as more of a bone quality problem, and hip replacement is a joint treatment. So there are a little bit of different apples and oranges here, where basically we do a hip replacement when the ball and socket joint have been worn away or been traumatized or damaged in such a way that the native hip is no longer sufficient with that patient's activities. And so we'll do a hip replacement in those cases. We don't really preemptively do hip replacements for bone quality problems like osteoporosis. So if there is a diagnosis of osteoporosis, meaning there's been a DEXA scan or some bone density testing where they can look and see that some osteoporosis levels or osteopenia is a consideration where the bone quality is not perfectly strong, then maybe there's some opportunities to use some calcium, some vitamin D, some physical therapy and weight-based exercises to help improve osteoporosis rather than jumping straight to a surgery such as joint replacement. Now, like we've talked here, there may be a need for joint replacement in someone with a really severely damaged hip joint, and then we would consider that osteoporosis condition in the context of that surgical treatment. But hip replacement's done for a bad joint. Osteoporosis is bad quality bone or worsening quality bone where it needs a medical treatment.
Yeah, I 100% agree. I think, we see a fair amount of osteoporosis in the office. And like Dr. Ellison mentioned, separating osteoporosis from osteoarthritis, which is, joint deterioration, wear, et cetera, osteoporosis being decreased bone density. So, osteoporosis, when I see folks who, have some mild hip pain, but they're not quite at the point by x-rays or symptoms of needing arthritis, but, we see that they've been diagnosed with osteopenia, osteoporosis through a DEXA scan or what have you. It's certainly a good conversation to have, with primary care doctor. Honestly, a lot of the local endocrinologists locally kind of manage osteoporosis and bone density issues as well at times. There are a host of medications, bisphosphonate medications, et cetera, that I personally, as orthopedic surgeons, we tend not to be the experts in that area. But I certainly think that if you're at the osteoporosis level, addressing it somehow through weight-bearing exercise, diet supplementation, or pharmacologic medication management with a host of those medicines is certainly reasonable. Not only, I think addressing osteoporosis is important mostly for decreasing risk of fracture, breaking hip, breaking wrist, lumbar spine, compression fractures, et cetera. Medical management of osteoporosis will hopefully reduce the incidence of a lot of that happening for folks and all. Awesome. Well, I think that's all the time we have for questions this evening. So thank you all for attending tonight's webinar. Just a reminder that there will be a replay of this on all of our social channels, including Facebook, LinkedIn, and our YouTube page. So again, thank you all for your attention, all the great questions. Appreciate you listening, and have a good night.
Okay. Thank you, guys.
Thank you.